Thank you, Dr. Rao. Thank you for excellent talks, Dr. Carbone and Dr. Hirsch. Today we'll have a brief 2 cases, and we can focus on small cell and then also EGFR mutation. So this one is actually a 65-year-old male, very fit man with extensive stage small cell lung cancer. He has a very high disease burden in the liver. So as a standard protocol, he got carbo, etoposide, and durvalumab. That was actually almost 2 years ago. And he had second-line lurbinectedin, and he had third-line docetaxel. Actually, May 2024 was the landmark for small cell because of tarlatamab approval. But by the time we started the treatment for him, he was symptomatic and progressing. We had to go with the docetaxel, waiting for the tarlatamab. So unfortunately, it did not work well, docetaxel, and then we had to go with tarlatamab for the 4th line. He had excellent initial response. He tolerated very well, but tarlatamab is a new drug. It is actually first BiTE approved for any solid tumor, which is amazing, So a lot of people had great responses, but this particular patient had actually response only for 4 months, and then he had a progression of the disease. He still works full-time. His ECOG is 1. I did not put 0. He's actually probably 0. What is the next options? I mean, we're talking about small cell 5th line and 6th line, which is amazing. We don't see with every patient usually. But what are the other options we have available for this particular patient? So Dr. Carbone?
Well, it is amazing to even talk about 5th line for small cell. But it is true that the median survival for 3rd line tarlatamab is more than what you see with 1st line chemo IO. So I'm really excited about some of the durable responses we've seen with tarlatamab. But in this setting, it's dealer's choice. I mean, really, there's no right answer here. Obviously, clinical trial is the only right answer, but there are not many trials in 5th line small cell. Probably what I would do with this patient is recycle a platinum doublet. He hasn't had chemo for almost a year, and he hasn't seen platinum for a couple of years.
At least year and a
So
half,
I'd probably try platinum doublet again if he's got a good performance status.
That's great. Thank you. Dr. Hirsch, we used to have a lot of excitement about ipi/nivo for small cell. I know it kind of faded away with all the new drugs coming in. Any role for slow-growing small cell with not much extensive disease in the liver or anything like that? Any role for combination immune therapy in these patients?
Ipi/nivo was tried in a large study, but we are talking 5th line treatment for small cell lung cancer. First of all, I think our group would have put tarlatamab much more upfront in the treatment scenario today. It is a dealer choice and a shared decision-making here when we come to 5th line treatment of a patient with small cell lung cancer. I don't know even what the performance status is when they are coming out there.
Yes.
But ipi/nivo would be in that decision scenario. I think it needs to be discussed with the patient. But again, tarlatamab will be more.
I have seen good durable responses in relapse small cell with ipi/nivo,
Yeah.
so that would be on my list.
Yeah, that's great. So if we have the same patient now, 65, very fit man, extensive small cell, would we do differently? I mean, that is a question. Jason, what do you think? I mean, we had chemo immune therapy, we have Caspian data, we have Empower data, wonderful, we're kind of stopping there. So what to add, for example, to the maintenance drugs or, addition of any new drugs to the immunotherapy?
Yeah, since we didn't see really good long-term control with immune therapy, like Empower One, and the Caspian data, 12 months versus 10 months, you know, and we know that the 12, like, I guess at 12 months, we expect to see, you know, very few people actually have control of disease. We really need chemo. It's a chemo kind of dependent disease right now. And so we have Inforte that'll add the lurbinectedin to the atezolizumab. That data is not yet released, and I know it's a positive trial. I just know it. I feel it. And I'm waiting on it because I feel like I'm holding out on patients who really need a chemotherapy maintenance. Some people call it early second line. It's not really a maintenance. We're just kind of treating disease that was going to relapse anyway, so just doing early second line therapy. But adding lurbinectedin in a maintenance setting, bringing tarlatamab up to consolidation or a maintenance, you know, obviously options that we want to look at. But even that is an immune-mediated disease control that I don't expect to see a lot of, you know, patients respond to that early. So I think we also have ADCs, which I agree I'm not that excited about because we get away from targets, but B7H3 targeting in small cell is something that we can do now.
Yeah.
Not in fifth line, unfortunately, with the clinical trials. If it had been earlier, I agree with Fred. If this were in 2025, we'd probably use tarlatamab much earlier than, you know, sequencing all those chemotherapies, which could have suppressed the immune system.
Yes.
So much to do. It's exciting in small cell, but I think that still the immune therapies for long-term control are only going to affect certain patients. So continuing to subtype and bring those therapies
That's
to
true.
patients that are specific.
Yeah, Inforte actually, they announced both PFS and survival benefit. Is actually adding lurbinectedin early, you know, with immune therapy. After chemo immune therapy, they're just starting, you know, lurbinectedin with immune therapy, you know, so with the Tezo. And both PFS and survival benefit, we don't know the numbers yet, the final numbers yet. So the sequence is important, of course, Jason, like you mentioned. So Dr. Carbone, would you use lurbinectedin as a second line or tarlatamab for these patients?
Absolutely, 100% for sure, tarlatamab, second line. Lurbinectedin PFS, median PFS is of just a few months. It's pretty toxic. Tarla has some acute toxicities, but not a lot of high-grade ones. And then after the first few cycles, it's like giving water in the clinic, and it has super durable response. I have one multiply relapsed small cell patient that has had a continuous complete response off therapy for 3 years now with Tarla.
Yeah.
So clearly the most effective thing earlier on, and I'm excited about first-line Tarla.
Yes.
In small cell. And in fact, we have a pilot study looking at Tarla monotherapy in first-line small cell.
That is amazing. What do you think of platinum resistance, Dr. Hirsch? And tarlatamab can do better in those patients compared to platinum-sensitive patients. So it makes sense to use tarlatamab for second line in those based on the data?
Use Tarla as second line?
Yes.
Yeah, that is what we will probably do. I'm also looking forward to see Tarla in first line. I'm of course sad to see etoposide disappear.
Yes. And
that was my student project when I was in Copenhagen many years ago and led to FDA approval of VP16 at that time. Yeah, that time, etoposide later. We need certainly new first-line options.
Great.
Of course, immunotherapy in the first-line setting is a development, and the targeted therapies. We need to learn more about DLL3, how to use those drugs. We give them to all comers these days, but I think research will learn us to also in small cell scenario personalize.
Luckily, more DLL3.
By the way, there is an upcoming small cell meeting. ISLC has every year a meeting in New York focusing on small cell lung cancer, and I can recommend that meeting. There is amazing science.
That is great. Actually, CD47 DLL3 combo is coming too, which will be amazing. Thank you. So, Dr. Gieschen, what do you think of both the limited stage and extensive stage? Any role for PCI in these patients like prophylactic cranial radiation?
Yeah, so prophylactic cranial radiation comes from the knowledge that about 50% of patients with small cell lung cancer will ultimately develop brain metastasis. So in the 90s, they looked at, can we treat these patients with prophylactic cranial radiation? And actually, it seems to work. And in a study by Alprin, there's a meta-analysis that did actually find that we have a 5% survival advantage in patients that receive PCI. However, we also know from studies of treating patients with brain metastasis that whole brain radiation can be very neurotoxic. And a patient study by Brown showed that if you compare gamma knife treatment plus gamma knife treatment with whole brain, that patients that had also the whole brain treatment had like 50% more, almost double actually, neurocognitive declines. So to avoid that, we know that most of the memory function is actually located in the hippocampus. So can we actually treat the whole brain and spare the hippocampus selectively with IMRT and have the same outcome? And it seems that patients, when you spare the hippocampus, have a better neurocognitive function. So I think we're moving in that direction. However, some patients may even have the metastasis in the hippocampus. So the question is, how many do have that? There was a study by Gieschen et al., and they actually looked and found that when you look at the distribution of brain metastasis, 86% are actually 15 millimeters or more away from the hippocampus, and only 3.3% were directly in the hippocampus. So I think based on that, you can actually go ahead and treat with hippocampus-sparing whole brain treatment and spare some of the neurocognitive function. That is actually currently being evaluated in the NRG CC03 trial, and they compare hippocampus sparing with memantine versus whole brain treatment. Now, finally then we have to say, do we really need prophylactic cranial radiation at all? And the question comes because when you take a look at the studies from the 90s that had the 5% benefit, they actually treated patients without looking first, do they have even actual brain metastasis, like an MRI right before cranial irradiation. And actually, it's conceivable that some of those patients were actually treated for their brain metastasis rather than having real prophylactic cranial radiation. And so there is actually in the extensive stage small cell situation a trial from Japan, Takahashi, and they actually compared prophylactic cranial radiation to serial MRIs every 3 months, and they actually found that there is not much of a difference there. So you can treat when it happens, and you can spare a lot of patients the neurotoxic side effects.
Yeah.
In the limited stage, we don't know that quite yet, but we have actually a trial going on, the Maverick trial by the SWOG, and they compared exactly that to see if we actually needed prophylactic cranial radiation or just observation. So we'll stay tuned.
Yeah.
Most patients, when we discuss it nowadays, elect actually already not to go with PCI, and the Memorial Sloan Kettering looked at their experience and they found that only half of the patients actually agreed to this. In my practice, I think it's less than that.
Yeah, hopefully SWOG trial 1827 will answer that question, the Maverick trial. So it's a prospective trial, MRI with or without PCI. So moving on to non-small cell EGFR, this is a common problem we have. EGFR mutated patient, she's 91-year-old. She had 5 years, almost 4.5 years with osimertinib. Now, adenocarcinoma on repeat biopsy, it's not a small cell transformation. It is still there. Liquid biopsy is negative for any targets. The tissue was so small, we can't get any molecular profile, on the repeat tissue. She already had SBRT for the local progression. So what options we can do for her? I mean, Mariposa 1, amazing data, first line. Mariposa 2, excellent data in the second line. Dr. Carbone, what do you think?
Before you go there, can I ask clarifying question? She had local progression or
Local progression, but she already had the SBRT.
What site?
Left lower lung.
But no systemic
No systemic progression, other areas.
Okay.
She doesn't want surgery. She had liver lesions to start with. So anyway, she was widely metastatic to start with. No other areas actually had a progression. Only one area came up. We did SBRT, and the same area now progressing after a year and a half. So and it is still adenocarcinoma. It's not small cell, but no targetable mutations on the liquid biopsy.
So the progressing site was biopsied.
Yes.
And I always prefer local therapy for local problems. And so I would ask my radiation therapist if he could give radiation to that site, or we could use ablation therapy by non-radiation techniques. That would be my preference versus potentially wedge resection or something.
If she has a multi-site progression.
Oh, that's
what do you
completely
think?
different situation. If
Yeah.
it's multi-site progression, I think the wrong answer is AMI laser chemo, because that really adding laser showed no benefit in Mariposa 2. So probably the best results we see in this setting are with AMI chemo as second line, if she's willing to tolerate the systemic toxicity.
Yeah. Jason, what do you think? If you see this patient now, I mean, fit patient, for example, EGFR mutated, never smoker, would you use osimertinib or osimertinib plus chemo or, amivantamab plus lazertinib? With or without chemo?
Yeah, so you had an unsuccessful biopsy.
First line I'm talking about is the same patient,
Oh,
kind of
first line.
maybe 60-year-old, very fit. What is your first line choice now?
So either AMI with laser or AMI with chemo. I would do either of those. I like AMI with chemo. It's been more tolerable than I thought it would be. I was worried about the toxicity. I had a patient drop to a systolic pressure of about 60 in the infusion suite, but recovered quickly and came back to therapy
Right.
and has had a beautiful response. So I've enjoyed amivantamab.
Well, you wouldn't use AMI chemo first line, right? It would be AMI laser first line.
Laser first line, yes.
No.
Yes.
If I understand correctly, this patient here started out with liver metastasis,
Yes.
right?
Yes.
So she started out with widespread systemic disease.
She had.
Now you have only local progression, so she has responded on osimertinib.
Yes.
So
5 years.
in this case, our group would focus on treating the oligoprogression
Local area,
and
yes.
continue
Yes.
OSI
Yeah.
because she seems to be
Yeah.
sensitive for that.
That's what I said. That's what I would
Yeah,
do.
exactly.
But you
That's
were asking
great.
me if I was starting front line.
Right, that was a separate
That is a
question.
separate question, But yeah, we have more options. Like we have FLAURA2 for fit patients. We have, amivantamab combinations. Hopefully, sub-Q, they will approve it. They rejected 2 months ago. So that's great. Thank you very much. And thank you for the listening. Thank you.